On behalf of the American Heart Association, I would like to welcome you to our HCM panel discussion. Throughout this session, you will have the opportunity to submit text questions for our speakers using the questions feature on your control panel. You may send in your questions at any time, and we will review them during our Q&A at the end of the presentation as time allows. To access live closed captions, please click on the closed caption button found on your screen. As a reminder, all sessions will be recorded and available in the coming weeks. My name is Renee Sednew, and I'm a Senior Program Manager at the American Heart Association. I will be moderating today's panel. It is my pleasure to welcome our esteemed HCM panelists. Heidi Salisbury is a clinical nurse specialist who co-founded the Stanford Center for Inherited Cardiovascular Disease in 2006. Dr. Ronald Wharton is the director of the Hypertrophic Cardiomyopathy Program at North Shore University Hospital. Next, Dr. Omar Weaver-Pinson, who all of you just heard from in the previous session, is an associate professor of medicine and is the director of the HCM program and Center of Excellence at the University of Utah. Dr. Ankit Bhatia serves as co-director of the HCM clinic at the Christ Hospital in Cincinnati, Ohio. Lastly, Dr. Richard Wright is currently chairman of the board at the Pacific Heart Institute in Santa Monica, California, and was previously director of the Heart Institute at Providence St. John's Health Center and is on clinic faculty at UCLA. As a reminder, full speaker bios are available in the event lobby. I want to first thank you all for being here today with us and for serving as our HCM champions. I also want to thank our audience. We have a very diverse group of audience members today, healthcare professionals, patients, family of patients, and others who are just interested in the topic. So I'd like to start today by first having each of you go around and share just a brief, 1 to 2 minute overview of what HCM care looks like at your system. Dr. Bhatia, why don't we start with you?
Thanks, Renee, and thanks for the opportunity to participate here. As we know, HCM is not one size fits all, and we're all going to find our own ways to kind of take care of our patients. There's no right way to do it here. So I joined Christ Hospital about 2.5 years ago. We're an integrative health system with one central hospital in downtown Cincinnati and numerous clinics and testing centers throughout the suburbs. Traditionally, hypertrophic cardiomyopathy had been housed by individual clinicians and NPs based on their various locations throughout the city. So no one really had more than just a couple patients. And although we thought we were doing it well, we ran our own data in 2022 and realized that we were horribly not following guidelines. People were not getting their echoes, they weren't getting their MRIs, they weren't getting appropriate cardiovascular risk and sudden cardiac death screening as per guidelines. And so we launched our HCM clinic in September 2022 with a model of first focusing on InReach, where all patients were referred to see myself and my colleague, Dr. Mazur, who you met in the prior session. And we focused on that for the first year and now have achieved near 100% internal referral rate. These patients still see their primary cardiologist and maybe will see us once or twice a year, unless they're on mavacamten, a clinical trial, something that involves us having to play a more active role in their care. As year one kind of finished off and we were able to focus on our internal referrals, we then focused on more of a hub and spoke model, seeking referrals from other health systems. And those included Cincinnati Children's and our partners at Health Systems in Dayton. And again, our focus now as an HCMA Center of Excellence is really more, can we provide the more cutting edge therapy? So a lot of what we see with those patients that we're getting referrals elsewhere are clinical trial involvements, myosin inhibitors, and other more kind of advanced therapies for HCM. But yeah, that's kind of our model in a nutshell.
Wonderful. Dr. Wright, why don't we turn to you?
Okay, well, thanks. So we have a slightly different model. So I'm at Pacific Heart Institute. Now, Pacific Heart Institute is the largest private practice in Los Angeles. We are affiliated with the Providence System, which is 51 hospitals on the West Coast. And I come from the heart failure perspective. I oversee heart failure for the 51 hospital chain. And what we're trying to do is to develop a sort of hub and spoke longitudinal care model for heart failure in the broadest sense of the word. And then what I do every day, which is what I would call thick heart workups and evaluation and management. And that, of course, includes hypertrophic cardiomyopathy. Most of our patients currently come from the Los Angeles region. LA County has 10 million people, so we have no dearth of patient potential. But we have in the Providence system over 17 million patients. So if you do the math, we're clearly underserving the hypertrophs that are in our community that I suspect are just not identified. So our challenge is really to identify them and then to put them on appropriate therapy. We are associated with both UCLA and Cedars-Sinai medical centers in Los Angeles. So for the non-longitudinal things like septal reduction therapy, if we need it, that's where we go. But for our longitudinal care, we're in the private practice mode where we follow patients. My average patient has been with me for 17 years. And our model is we have my heart failure nurse practitioner, my heart failure nurse, and my other half dozen nurses, and all the other people that help me manage these patients longitudinally. So that's the view from Santa Monica.
Wonderful. Heidi, I'm going to turn it over to you also in California.
Yes. Excuse me. Thank you, Renee. We can move up the coast from Santa Monica up towards San Francisco to Stanford, to Palo Alto, California, where I'm happy to talk about our center. We are the Stanford Center for Inherited Cardiovascular Disease, where we've been taking care of HCM families for decades, but we formally created a center to improve, recognizing what you've heard, just that HCM is underdiagnosed and in many cases undertreated. And so to meet the complex needs of this population, we formed a center committed to the HCM individual and families about 17 years ago. And during this time, our focus from the beginning was to create a model that provided a comprehensive intake of the needs of an HCM patient and a family. Every HCM heart looks different. And so we've learned over the years that to do this, a multidisciplinary team is key. So we have physicians, physician scientists and geneticists, nurses and advanced practice providers, genetic counselors, and then strong partnerships with surgery, imaging, family planning, and pediatrics. The team, this comprehensive approach really helps us personalize the care of the HCM patient so that we can focus on the needs, their individual needs, and their needs are dynamic. Your needs evolve and change over the lifespan and across the generations. So our team really focuses on that comprehensive multidisciplinary model of care. And then partnership with the individual patient and family so that we can be responsive to their needs, whether it might be improved updated imaging, whether it might be family planning, whether it might be surgery or access to novel therapeutics. And then partnership again with professional organizations, strong partnerships so that we are making sure to be in a position to advocate for new interventions, medications, and opportunities for our patients. And then finally, partnership with advocacy community, making sure that we have strong relationships with the advocacy community and our local community providers, cardiologists, so that we are able to reach as many individuals with HCM and families with HCM to continue to improve and positively impact their lives. That's our model.
Thank you, Heidi. And I know we're going to hear about that community engagement a little bit later today. We're excited for that.
Yes, absolutely.
Yes. Dr. Wharton, I'm going to turn it over to you.
Yeah, I can't be that eloquent. So I'm at North Shore University Hospital, which is the mothership of the Northwell Health System. Northwell is the largest hospital system and the largest private employer in the state of New York. We started our hypertrophic cardiomyopathy program here in 2019 when I came here from Montefiore Medical Center, where I was previously. The program got slightly interrupted by COVID, which took over the hospital for a little over a year, and there was no other diagnosis here. And then we started ramping up again as the pandemic started to subside. At the moment, I am told that I should have a nurse practitioner to help me out in the next few months, but until then, I'm doing everything. As the initial screening myself, we get referrals from cardiologists throughout the Northwell system, as well as from other healthcare systems in the area, such as Optum and a couple of others that are more local. We get referrals from about as far as 100 miles further east and about 50 miles further north, just because Northwell is as huge as it is. And Northwell pretty much has everything that I need, so I don't have to send things for anything elaborate most of the time. We have surgery, we have electrophysiology. One of the cardiologists with whom I work, who is part of this program somewhere during today, is also has a PhD in genetics. She does all of our genetic screening, and she also works with someone who has contacts at Cohen Children's Hospital, which is our pediatric division, because I don't see kids, so that we can screen first-degree family members, and if needed, we can start seeing people before they hit 18 years old as well. We have the entire gamut of things that you need to take care of these patients. We have electrophysiology, we have cardiac CT, we have cardiac MRI. The EP service here is extremely robust, so they perform everything we need, whether it's ablations or device implants. We do have surgeons who have done training in septomyectomy, although we have not needed to use them as much as probably we could have in past years. And I'm looking forward to getting a nurse practitioner to help me out with all of these things, which should be happening by July.
Thank you. And yet we're very excited for the genetics session later this afternoon with Dr. Azari.
Yeah.
Okay, so Dr. Weaver-Pinson, thank you for joining. I know you were on a session right before this and you shared a little bit about your model, but what we're doing here is just going around and sharing just high level, what does HCM care look like at your system?
Thank you, Renee. So we created our program in 2015, right? As I showed in the previous session, we serve not only the state of Utah, but also surrounding states. And half of our patients come from the state of Utah. The other half come from Idaho, Nevada, and all the other states that are around us. And when we create our program, again, was with the vision to be among the top centers in the United States, like we're doing today with the finest people in the field, right? And we also create the program with the mission of, again, provide the finest clinical care that we can, also engage in research as a way of furthering knowledge and also improve patient care and also education, as we show in our previous slides. We created this multidisciplinary team, as you saw, and we try to provide a personalized and expedited evaluation for our patients, whether they come from out of states or from the state of Utah, to try to minimize the time that they spend with us and trying to keep them as close as possible to their communities. And as you learn from our shared care model, we build and continue to build and maintain our relationships with different centers, different providers in the state of Utah and surrounding states, and with the use of telehealth, trying to, again, fulfill the goals of keeping the patient closer to the community. So I'm proud of being here with all this group of experts, and looking forward to a great conversation.
Thank you all. And as everyone can see, we have just a wide variety of HCM care models, and it's really been a pleasure working with all of you over the past almost a year now, and discussing barriers and strategies. So thanks again for being here. So I'd like to move to imaging. So just would love to hear from each of you just to talk through, broadly on what you think of the role of cardiac imaging in HCM care. Dr. Wharton, I'm going to hand it to you to kick off this discussion.
Sure, thank you. In a word, it's essential. And, the care of HCM patients requires a lot of things. It requires cardiac MRI, Sometimes you get CT scans if you want to look at other things associated with the heart, not necessarily the muscle itself. But it all starts with echo. Echo is what makes the diagnosis. Echo is what follows the diagnosis. And if your echo machine is only as good as the sonographer who picks up on the findings and the interpreting physician who understands what they're looking at and acts upon it appropriately. And if any of those things in the chain are broken, it remains under the radar. There is a tremendous amount of variability in echo machines and echo knowledge and education, and that contributes often to, regrettably, the delay in diagnosis. I think the HCMA, the Hypertrophic Cardiomyopathy Association of America, reports that patients usually go between 3 and 5 years between the onset of their symptoms and when they finally have a diagnosis. And part of that is getting them to an echo, and part of that is making sure that the echo is read appropriately. Every month, I get a couple of referrals from my colleagues over in structural heart. They have patients who've been referred to them by outside cardiologists for consideration for transcatheter aortic valve replacement because they've been misdiagnosed with aortic stenosis. And then when the patients come here, someone looks at the echo, someone else looks at the echo besides the referring physician and realizes that in fact HCM is not their problem. So accurate echo is absolutely essential for finding this condition. Accurate echo is absolutely essential for managing this condition. And the other thing I'll also add is that many patients with hypertrophic cardiomyopathy, not everybody with hypertrophic cardiomyopathy has an obstructive form. And the non-obstructive form often requires the addition of an ultrasound enhancing agent in order to see the echo as well as you need to. And that to this day, at least in the New York area, I have never seen an outpatient cardiology practice use an ultrasound enhancing agent. It's probably too cumbersome for them to store. It requires putting an intravenous line in effect. And when we have it here, it makes all the difference. And without them, I can only imagine how many patients we would not diagnose as well. So that's my word on imaging.
Ron, can I ask you a question? So I also run our Echo Lab. One of my beefs about the Echo, and you're a fellow of the American Society of Echo, the official Echo report requirements of that Echo Society are that the septal thickness be reported at a certain part of the septum. And so a lot of reports will come back that somebody has a septal thickness that is normal, like 1.2 centimeters. But a centimeter down the septum, it's 1.8 centimeters. And
Right.
somehow that doesn't make it on the Echo report. In your institution, or I'll ask the others too, is there a data box on the Echo report that doesn't say septal thickness, which is according to the ASE where the mitral valve leaflets are, et cetera, but maximal septal thickness where you don't have to report it in your verbal report? Because to me, that's the biggest screening failure, is that people don't recognize that further down the septum, there's this huge septal bulge that wasn't reported on the Echo report.
Oh, you're 1,000% right. And, you know, Echo reporting systems can be tailored, you know, in academic medical centers to how you want them formatted, and everybody's on a different platform, you know, but there are lots of different vendors. Regrettably, where I work, there is no specific drop-down menu. So what I do is, in all of these patients, I specifically type in basal septal thickness, maximal basal septal thickness is this, with the understanding that not everybody has a uniform septal thickness. In fact, most patients with this condition do not. So point well taken. And I you know, for somebody who runs an HCM program, I have to actually, you know, add some free text in order to make my point across, because there isn't any standardization, and that's something that we should probably bring up at ASC this year.
Dr. Wharton, that makes me think of something that might be really helpful to the audience, which is, you know, while clearly the message is HCM patients need quality imaging and quality sonography, well-trained sonographers, do you have any pro tips on when you're placing, for those who place the actual Echo order, what specific parameters they can add so they don't just end up with your, you know, basic wall motion and function? what are the 5 points you would suggest they add? Maximal wall thickness, resting, Valsalva, et cetera.
Right. So that predisposes that the ordering physicians knows what they're looking for.
Right.
And now if they do, that's great. And if you write, when we request echo specifically for HCM here, I'm fortunate that I work with sonographers that know exactly what they need to do. However, the bigger problem, nationally is the number of patients who fall through the cracks. One of my patients who is still a practicing internist, even though he's 80 years old, had not been diagnosed for years, even though he'd had 3 syncopal episodes every time he stood up. And all the echoes are being done when he's lying down. But as soon as you stand them up, the LVOT velocity goes from 1 to 5. And that's really the whole point is that there is a wide variety of orderers. And obviously, I don't think any echo lab can tailor its requisitions to who's ordering and what. There are just too many. So I think what needs to be done is sonographers have to recognize either when obstructive physiology is there or when the harbinger of obstructive physiology is there. Sometimes you may just see a large area of discrete basal septal thickness, as Dr. Wright alluded to earlier. You may see systolic anterior motion of the mitral chordae in a resting study. You may see enough of the things that would say, I'll bet this person could really have obstruction, remembering that you cannot evaluate a symptom with exertion with a test at rest in many, many patients. And therefore, when sonographers, with a person who holds the wand, holds the power. So if the sonographers are sophisticated enough to either not necessarily see SAM, if they see it, it's great, but if they see the precursors to SAM, those are the patients that they need to act upon to do the extra things, either stand them up or Valsalva them. I've had some patients who don't Valsalva that well. What I do is actually I have them come off the stretcher, stand up. We will scan them standing up just to get the LVOT gradient. And if necessary, I even have them do a few jumping jacks next to the bedside. Now you might laugh, but you can do that exercise, and at the same time, you don't have to unhook them from the machine and then hook them back up. So you get exercise quickly and do that. But I think the best way is really to make sure you have a top-notch sonographer for us, because this way all comers are evaluated as they need to, irrespective of who's ordering and who's not.
Can I ask you, Ron, and the other experts, and from Utah and Cincinnati and Stanford, how far do you push provocative maneuvers? Now, obviously, it's important, particularly because of current restrictions on use of the myosin inhibitor therapies, to document an obstruction. So does anybody here give nitroglycerin? Do they, if somebody only has a gradient with post-exercise, do you exercise them every time you try to make an adjustment in the myosin inhibitor therapy, et cetera? I mean, what do we do to make it easier to elicit gradients, which are, although, as you'll hear in my talk a little bit later, I don't think the gradient is what drives most symptoms, but it's one of the markers that we do to identify the disease. So it's really important that we elicit a gradient. So
right,
I'd hear from the panel what they do to elicit a gradient.
Right.
That's a great question, Richard. I think so. So echo is a cornerstone, right, for the diagnosis and management, as you guys had already mentioned, and when it comes to assessment of gradients, right, we have to, as Ron said, the sonographer is the first line. Right? If he doesn't identify HCM, nobody else will, right? So he has to identify, but it's from us, right? The teaching has to come from us. We have to educate them. We have to teach them, develop protocols so they can really do what they're supposed to do, right? We had to, we had some sonographers that sometimes they give us some mixed images of LVOT gradients with mitral regurgitation, right? It becomes a challenge. Some of them think that it's very cool to use very low sweep speeds, right? Where sure we get a lot of CW envelopes, continuous wave Doppler envelopes, but we really lose that shape of the envelope and makes it sometimes more difficult. So those things that we had to work with our sonographers. Going now back to the reading person, because ideally we do look at all our echoes, right? But as Ron is complaining already, he's asking for a nurse practitioner for the last, 5 years, I don't know, and he's just gonna get it in July, right? So he cannot look at all the echoes. So we need, people out there, you guys that are watching this, to really kind of up our games and trying to identify the disease. Now, when it comes to our, how aggressive we are provoking those gradients, in general, we use just physiological measures, right? That's what we do, right? We use the typical Valsalva, and we have some very excited sonographers that they do squatting and they standing, and those are measures that are fine. Now, when it comes to the management of myosin inhibitors, as you said, this is really important, especially month 3, right? At 12 weeks when we can change the dose. In those cases where we see and we suspect that the patient is still having symptoms as there's residual obstruction, what we're still doing, we do get the echo. We say there's no gradient, you're having symptoms. I suspect that you're still obstructed. Then we bring that patient, we give the patient the option. Okay, well, we can wait 3 months because the patients get tired too, right? Of getting all these echoes, but we can wait 3 months, or we can act now, bring you, a few weeks, get an exercise stress echo, right? And we demonstrate that you have obstruction. That will give us the option of going up on the medication, right? So that's what we're doing. And in some cases, we do even incorporate like postprandial type of provocation in addition to the exercise too.
Yeah, what I'd say from our side is that we struggle. We started trying to do a lot of education, but we have 7 testing sites. And it wasn't really, we were still running into issues with lack of adherence. So from the sonographer and from the reader perspective, in terms of what the clear kind of expectations were for HCM echo. So we actually created a new order within Epic for a hypertrophic cardiomyopathy echo. We made them all go to a single site, have 6 sonographers down there. The expectation is, unless there's some reason they can't be, 2 sonographers touch the probe at that point. And then we have a select group of 3 readers on the back end. And if there's any ambiguity as to obtaining the appropriate gradient or whatnot, the patient stays there till the images are at least looked at initially to determine if further images are needed. From the provocation standpoint too, for our so I'll exercise someone to begin with to establish their peak gradient, but usually not routinely with the typical myosin inhibitor echoes. But what we will do is just make sure that on all our myosin inhibitor echoes, it's not just the gradient. Those are becoming very limited and actually pretty short at a lot of sites as we keep getting more and more mavacamten patients. But we're doing it. We're trying to get a peak gradient with Valsalva. We're getting CDP estimates on everyone and reporting that on everyone as well. And then actually maintaining our diastolic dysfunction assessments, even on our limited echoes for mavacamten, just because I'm sure you guys have seen it as well, especially in the first 12 weeks, dropping from 5 to 2.5, many patients have developed symptoms despite not really being able to provoke a gradient.
That's why I stopped dropping people from 5.5 to 2.5.
Same here,
Yeah.
Ron. Oh.
What was I gonna say? The other thing I'll mention about the echoes is that in my experience, and I've treated probably somewhere between 70 and 80 patients now with mavacamten, is that you start learning other things about the mitral valve, which is why sometimes I think you need to do additional imaging beyond the quote unquote limited echo. A lot of these patients are older, as you know, Dr. Wright and I once discussed at I think it was American Heart. A lot of these patients are not genetic HCM, but older patients with thickened basal septums and SAM on that basis. And by the time they come to presentation, that mitral valve has taken a beating for years. And in some patients, what I'm discovering is that when you start treating with mavacamten, you start uncovering other things. You start uncovering other mechanisms of mitral regurgitation, which are independent of the SAM. You start uncovering prolapse in some patients, because what prolapse and HCM have in common is that both conditions have long leaflets. And I have a number of patients that I'm starting to see posterior prolapse as the SAM is mitigated with our current therapies. And also you will see patients who have restricted physiology. There are patients who have, because the same thing, they have a thick muscle for a long time. So you treat the SAM and they still have diastolic heart failure, which is what you go back to your point about maintaining vigilance about diastology, because one of the nice things about these agents is that by taking away the SAM, you can start treating them with medications that before you would have a lot of trepidation about giving them, such as, Entresto and SGLT2 inhibitors and the like. So we're getting to learn a lot more about the physiology of these patients as the newer drugs come out.
Ron, I want to I want to ask the panel about something you just broached. And as the panelists know, I mean, I have a particularly geriatric group of HCM patients. So my median age is 82 of my HCM patients, right? And I have people on MAVA who are in their late 90s now.
My oldest is 96.
Yeah, mine too, actually. So the question is, what do those people actually have? They have clearly the phenotype of HCM. They have, you know, a 2 centimeter thick septum and their EF is 74%, et cetera, et cetera. And yet you genotype them, and at least with our current technology, you don't find anything. So
Right.
What are we missing? I mean, I'll ask the panelists. I mean, do these people just have epigenetic stuff we don't test? Is there something different about them compared to the 22-year-old, you know, with overt HCM? What's the panel think?
And I'm going to jump in for just one moment. Such a great discussion, and just to, in the interest of time, and this is actually a perfect segue into our next topic. It's kind of related. Just for anyone, to answer Dr. Wright's question, or to talk about just how you treat a patient with HCM. So just that kind of broad question, open-ended. So either of those topics, anyone feel free to jump in.
Right. I don't know that, Rich, I don't know. Obviously, there are a lot of genes out there we don't know about, probably. In terms of treating them, obviously, we can treat them the same way because the physiology is still the same. I think it's an exciting time to be in the field because it's been 6 decades since Gene Braunwald initially described this condition. And up until a couple of years ago, we were using drugs from 3 classes of medications, none of which had any data, and all of which were repurposed from other conditions with modest effects and a frequent need to undergo invasive procedures. And the paradigm now seems to be completely shifted. I wouldn't raise my children to go up to be CT surgeons right now.
Yeah, so to reach our point, I think this is a very challenging group, right? This is an extremely challenging group because those older patients are those patients that present with that sigmoid septum, right? And those are the most likely to have a negative genetic testing. So we really don't know why they have. And this speaks to, when I started dealing HCM, in my mind, it was just pretty close-minded and say everything is genetic. But, over the years, I learned that this is not the case, right? And there are multiple factors that lead into this, and maybe a genetic predisposition with some, less dominant genes that it really, in the setting of obesity, hypertension, those are factors that have been associated with HCM, may lead to the phenotypic expression of the disease. But certainly it's a challenging group. I agree with Ron. I think they can be approached the same way. And there are trials now when it comes to obstruction. When it comes to relaxation, the jury's still out, but I think there's some trials like Embark HCM that is testing the use of myosin inhibitors and HFpEF, and it seems that it's gonna show some promise there. We'll see. But yeah, certainly it's a challenging group to treat.
Yeah, I want to bring up one thing you mentioned. So my oldest hypertroph was 102. She had a negative genotype, but both her sons now have HCM in their 60s, right? So it's clear in that person, I do think it's genetic, except we don't know.
We don't know the gene.
Right.
We don't know the gene. And we have those patients that, like, I walk in the room, the patient has like hypertensive emergencies and why not? And I'm like, this is hypertensive heart disease, no question about this, right? And when I look at the echo, I start seeing like CRIPS, right? Which we know that are associated with, genetic type of cardiomyopathies, right? And other findings that make you think, or myocardial bridges and things like that, that it makes you think, hey, well, we really need to give a second thought to this, right? Before jumping into just the easiest path
Right.
of assumptions.
The biggest difference between the two groups, I think, is obviously the patients who are in their 60s and beyond. Most of them, and I'm excluding the mid-cavitary ones with the apical variants for a second. I'm just limiting it to the obstructive ones right now. Those patients have pretty much selected themselves out for being very, very low risk in terms of ventricular arrhythmias and that sort, sudden death. But the approach to the HCM physiology is independent of whether you find a gene or not, because what they have in common is that the mechanism of SAM, which was so eloquently demonstrated by Mark Sherrod in 2000, is still that the power is too high and that the flow patterns in the ventricle have changed such that the mitral valve is being pushed in the way of the aortic valve. And since the physiology is the same, the treatment will work independent of the genetics or the lack of understanding of the genetics on our part.
I agree. The push and drag mechanism. Now, because we don't want to ignore Renee's question, right? Like how we approach these patients, right? And I think has been mentioned today and over the previous seminar, where when I get a patient referral with HCM and the way they will approach it has been mentioned, right? We look at 5 pillars where we're trying to address patient symptoms, right? We're trying to address the patient risk for sudden cardiac death. We're trying to address genetics and family screening. Right. We also trying to address exercise recommendations, which there's more and more data nowadays, right? And we can spend hours talking about this. And obviously we try to assess the arrhythmias, right? Other than ventricular arrhythmias and the risk for sudden death, right? And there have been a lot of discussion about certain topics, but when we approach a patient from the symptoms perspective, right? And it's kind of related to what we have been discussing, we classify the patient, as Ron said, in patients that have obstruction and no obstruction. Right. And I know Ankit has a lot of experience in patients with non-obstructive, but the patients with have obstruction, right? And that's based on echo, right? LVOT peak gradient of 30 millimeters of mercury make the diagnosis, right? Either arrest or with provocation. We call those latent obstructive patients, the one that happen only with provocation. We use repurposed medications that had been approved for other indications, right? But knowing, again, as Ron mentioned, the pathophysiology and the substrate that are involved in obstructive physiology, we have used the beta blockers, right, to try to increase the filling time, trying to decrease the contractility of the heart, right, to minimize SAM and septal contact. So we use calcium channel blockers, beta blockers. We use also disopyramide, with also has been there's some data published by Mark Cherry, right? The multi-center trials showing the efficacy and safety of that. But as has been mentioned already many times in the forum, now there's a new kid on the block, which is the group of the myosin inhibitors, right? Which again, mavacamten is the one that's FDA approved now based on data of the Explorer trial. With good efficacy endpoints when it comes to functional capacity and also symptom burden, also shows significant reduction in gradients. I don't know if Ron has any more comments about the Explorer trial of myosin inhibitors in obstructive physiology. I know Ankit has a lot of comments perhaps on the management of non-obstructive patients.
Well, it's a game changer. Dr. Wright has a patient population that's probably similar to mine, a lot of young people, but a whole lot of older people. And you're giving them the lives back, many of them. Before myosin inhibition, we still, as I mentioned, had a lot of patients who still required procedures. And Milenda Desai's trial, the Valor trial, which was published in 2022, clearly shows that when you give these agents, the number of patients who still need a procedure goes down dramatically. The drugs work, and they work very well, and they work with minimal side effects, and they also work so well that you can get them off all of these other drugs. So
yeah, I'd like to second that. I mean, what Renee asked. So because I have a geriatric population, all of them get tested for mimics of hypertrophic cardiomyopathy, because they're just as the Venn diagrams overlap. And the big one, of course, is amyloidosis that can mimic it. So 100% of people get AL and TTR, the standard workup we do for that. And then, of course, there are the conundrum of some older people that have monoclonal gammopathies, but they also may have HCM, and that workup becomes much harder. And in fact, some of those people, you may have to rely on tissue procurement to make the diagnosis. Once we make the diagnosis and we're pretty convinced, and since there is no 100% assurance in the elderly population with HCM that they have HCM, because most of them are genotype negative, so it's a syndromic diagnosis, and as you said, predicated largely in echo findings. Our primary therapy, our go-to therapy is a myosin inhibitor. The beta blockers don't improve exercise. They don't improve diastolic compliance. Most of these people have symptoms related to exercise-induced or even at rest increased left ventricular end diastolic pressures. And hence we give a trial for 100% of people, assuming they can afford it, et cetera, that they go on mavacamten. And that's our current approach. Obviously, a lot of these people, as was mentioned by others, Not so much ventricular arrhythmias, because in the elderly population, that's less of an issue. It's mostly atrial arrhythmias. So a whole ton of them, half of our patients have AFib in our HCM program, and that has to be dealt with. We love ablation, except these people usually have atrial myopathy, and ablation is less good long-term for these people. So many of them will need rate control, and hence they may end up being on diltiazem or a beta blocker just for rate control, but not to make their HCM better, because I'm a diastologist, and lusitropy, the relaxation, is not improved by those agents. So that's kind of what we do in a nutshell: full workup, and then a trial of a myosin inhibitor.
So I think this is the perfect segue then into non-obstructive, because I think there's a lot of overlaps. And, as we know, myosin inhibitors are approved right now for obstructive HCM. But I think there's one common theme we're seeing throughout this panel, that as we've all moved on and progressed in this field, the use of myosin inhibitors are realizing that obstruction is less and less kind of the hallmark component of HCM that we think it is. And HCM really is a condition of the myocardium. And diastolic dysfunction is a big role in that. So I know Omar had done a great kind of overview of obstructive HCM. When I'm looking at a patient with non-obstructive HCM, traditionally the folks with the provocable gradients below 50, I view them very much like I would HFpEF. And I've got being the advanced heart failure transplant side of the HCM clinic here, I get a lot more referrals in that sense. So I'm seeing those patients, and when I'm seeing them initially, the non-obstructive, I'm starting with biomarkers. Biomarkers don't lie. NT-proBNP, patients can. And it's a good marker of what their level of strain is and where they're at currently in their disease process. And one thing to know about non-obstructive HCM, especially many of them, as Richard mentioned, are going to present with atrial arrhythmias initially. And that leads to their HFpEF non-obstructive HCM diagnosis, as opposed to vice versa. So I start with the biomarkers, and then for folks showing signs of clinical congestion, signs of heart failure-like syndromes, they get put on the standard HFpEF therapy, usually starting with SGLT2 inhibitors. Got the upcoming sotagliflozin-related trial related to non-obstructive HCM, but not too much dedicated data right now in non-obstructive HCM and SGLT2s, but it's coming.
Right.
And then addition to that now, we just completed Odyssey, just completed all its enrollment. That was mavacamten for non-obstructive HCM phase 3. Aficamten, the Acacia trial, is just starting, and we're excited for that. So after SGLT2s, that's my next step, is to consider a clinical trial for them. And then finally, I've actually been a lot more dependent on remote monitoring, specifically CardioMEMS in these patients. They're uniquely challenging. CardioMEMS, a pulmonary artery pressure sensor, to help manage volume status, because these patients can be very volatile. They can come to hospitals with small amount of fluids. They tend to have a lot of left-right mismatch, meaning that their wedge pressure can be 25 at baseline and their RA pressure can be 5. And so with that, then I find the CardioMEMS a very useful tool there. And then finally, we got to think about the fact that if you got end-stage non-obstructive HCM, and they're showing objective signs of their heart failing, low cardiopulmonary stress tests, low cardiac indices, and these other things are not working, there is a path to get these patients transplanted. And even if they don't meet criteria for a higher status, they can at least get status 4. So something to consider. It's still a minority of our patients, but something I don't think we think of soon enough. And what we end up running into in non-obstructive HCM is patients that end up effectively drowning in their own fluid. Years of high filling pressures leading to renal failure, hepatic failure, and then by the time you consider transplant, they're not a candidate. So it's something to keep in the back of your mind for that patient population.
One thing that you probably are aware of, because you partook, we were also partook in Odyssey, and it was very interesting that in the middle of the protocol, in the middle of the trial, the protocol was changed so that after week 48, everybody got converted to open label mavacamten. The Data Monitoring Safety Board could not possibly have made that recommendation unless they were seeing a signal that could no longer justify the placebo arm of that trial. And we know from the precursor of Odyssey, just as we know from Redwood, which was this phase 2 trial for aficamten, that when we give these agents, the BNP goes down and the high sensitivity troponins go down. So we know we have signals there as well as this clinical signal from the Odyssey trial that we just completed that, as former Vice President Dan Quayle said at one of his speeches, the future will be better tomorrow.
Can
Heidi,
I
I
ask
will
you guys, do you use NT-proBNP to help adjust your doses? I mean, we know from the clinical trials that there's a robust reduction on the drugs we're talking about. But what if there is no reduction? Does that mean the person isn't responding and you should go to a higher dose?
And I'm so sorry to interrupt. We have just under 5 minutes, and I wanted to, Dr. Wright, thank you for your question. I just wanted to give check in with Heidi on the treatment question, and then if you don't mind, then we'll get back to that question just right after.
Oh, cliffhanger. Thank you, Renee.
Or feel
Yeah,
free to
so-
answer Dr. Wright's question too.
Right. Yeah, no, I think we can't leave that one hanging. Yeah, no, I think that there's a lot of hope there in using NT-proBNP and looking for that the perfect biomarker to help guide titration. So we have used that in our practice more on a case-by-case basis. But did anyone want to close the loop there? Yeah, 'cause that's
I'm
a big
going to add to that. That does get concerning to me. And of course, I still generally follow the kind of REMS related guidelines on dosing too, but I'm much less willing to reduce. And I'm definitely using it at the 12-week to make sure it's, especially in the borderline EF, it's not someone whose NT-proBNP is going up too, as a marker of them being more indicative of low output and kind of burnt out to the point beyond which the myosin inhibitors would help them.
So when it comes to the obstructive population, we don't routinely check for NT-proBNPs, but I think it's going to be, we should do in the non-obstructive population though. Because besides making sure that it's safe and there's no drop in the ejection fraction, we do need to have some, and obviously we have patient-reported outcome symptoms, right? But I think we have to have some objective measurements also that patients are improving when it comes to non-obstructive.
I agree. And we'll have echo data too, not just ejection fraction, but all of the
That's
markers
the-
of histology. If we, Explorer had echo and MRI sub-studies, and there was MRI sub-studies recently released from Redwood on the aficamten side. And in all of these things, we're seeing the same things. The left atria are getting smaller. The indices, crude that they are on echo of diastolic function, are improving. The degree of mitral regurgitation as assessed by core labs is going down. So, all of these ingredients that lead to the atrial fibrillation happening, which is so ubiquitous in our population, are being mitigated.
One thing I want to make sure in our final minute, Dr. Wharton, is just that in the spirit of treatment, having heard this rich discussion and all of the, everything we've learned, how far we've come and how much hope there is now for our patient population, I wanted to highlight a point. Dr. Wright, you talked about the older onset phenotype or expression of HCM, and many people related to that. You mentioned that while the genetic testing may be low yield for the older onset population, that both the sons of that individual end up having positive phenotype for HCM. And I just wanted to highlight the point that especially while there's so much hope for the treatment of HCM, the importance of family screening and remembering whether it's older onset or younger onset to do a thorough family history, as all of us do, but really to advocate for when you're diagnosing HCM at any age, family history and family screening, and ideally genetic testing and counseling is key.
Sure.
And I think that brings us to Renee.
Yes, thank you, Heidi. That's a wonderful, note to end on that, instilling that hope for our audience here. So I'd like to thank all of our 5 panelists here, Dr. Wharton, Heidi, Dr. Wright, Dr. Bhatia, and Dr. Weaver-Pinson for being part of this discussion, for sharing your ideas, insights, and for all that you are doing as HCM champions and all that you do in your communities for your patients. So coming up next at 12:45 Central, we have one of our panelists today, Dr. Wright, will be presenting HCM, a primary form of heart failure. So to access this session, simply leave this session and then click from your lobby, click on the sessions from the menu and click on that session that you'd like to join. Thank you very much for attending today's HCM Connection Forum, and we'll see you soon.